Welcome to RSDSA's third annual virtual conference, Treating the Whole Person, Optimizing Wellness. My name is Alexis Davis. I'm the social media manager here at RSDSA. I'm joined by Jim Broach, Executive Vice President and Director of RSDSA, and this year's first virtual conference guest, Dr. Elan Schneider. Dr. Schneider is a physical therapist specializing in neurorehabilitation of chronic pain. He co-founded the Retrain Pain Foundation, a nonprofit organization dedicated to pain education, and has created educational content used in pain clinics throughout the world in over 30 languages. Dr. Schneider is also the co-founder of TrainPain, a digital health company developing novel technology for pain-related neuroplasticity. He is optimistic about the future of pain care and is a passionate advocate for public awareness of modern pain science and its implications on policy, healthcare systems, and improved patient-centered care. We loved having him earlier this year. We knew that we had to bring him back for our conference, so we're just so happy that you all were able to join us. As a reminder, remember that while the information shared here today is helpful, please consult your physician for personalized medical advice. And also be sure to leave comments and questions in the chat for Dr. Schneider throughout his presentation, as we will leave time to answer your questions at the end. And finally, and then I will stop talking, if you know anyone who has not registered for the conference yet, tell them that it's not too late to register. They can join us right now. They can join us this evening. Send them the link. I'll put the link in the chat so you can send it to any friends and family members. It's not too late to join our free conference. And that's all for me. So Dr. Schneider, I will let you take it from here.
Okay, thank you, Alexis, for that kind introduction. And thank you, Jim and Alexis, for giving me this opportunity to share with the group. I really appreciate it. And I just want to acknowledge all the work that you guys are doing to support the CRPS community and the caregivers and advocating. And we really appreciate it. And I also want to acknowledge everybody. I can't see you, but all the people who are here, I just want to acknowledge, what you've been through and the pain that you have been through and are going through in this challenging situation. And I know it's not an easy journey, and I just want to acknowledge that before I share my thoughts. So my background, I'm a physical therapist. I started my career about 16 years ago in neurorehabilitation, not specifically focused on pain. But pretty much right away, I got really fascinated by pain, really interested in it from a few angles. First was just the general issue of suffering in general, that people are really, really suffering and aren't getting the care that they need. And it reminded me of two close family members growing up who had severe chronic pain that were around me. So that touched me in a certain way. But also there were certain other issues that just I found very strange and interesting, which was, why was there such a mismatch between the amount of pain that people feel and the amount or the severity of the injury that they seem to have? Some people have what seems to be a very small injury, yet have a lot of pain. And there are other people that have, a lot of body damage, and you would assume they're in a lot of pain, but they're not. And why is there that mismatch? I was fascinated by why two people would have the exact same surgery and everything looked exactly the same on the scans. And one person would feel better and the other person would not, and perhaps even get worse. And the thing that really fascinated me the most was why people get better. We talk a lot about why people don't get better, or what's getting in the way of healing. I was really interested in why is it that anybody gets better? What are actually the key factors behind recovery? What aspects of therapy are actually really creating that positive change, and how can we do better once we know what's really helping? How can we do a better job at delivering care? I felt that I wasn't equipped enough as a physical therapist. So the next place that I looked was yoga. I became a yoga teacher, learning mind-body techniques, things like mindful movement and meditation. But what really opened my eyes was when I started discovering pain neuroscience. All this literature, hundreds, thousands of research studies that have been done and really shown a lot about how pain is working, and things that were very, very different than what we were taught. And it really opened up my mind. And I began to really focus on just treating chronic pain, in particular people with neuropathic pain, fibromyalgia, trying to bring holistic science-based care. And also got really interested in pain education. How can we take these ideas, which are locked away in these journal articles, many of them you can't even access if you wanted to because they're behind paywalls and they're generally indecipherable. how can we bring that information out and share it? And that was the inspiration behind the Retrain Pain Foundation, which I started with two physical therapists, Rob DeLillo and Greg Holstrung at H&D Physical Therapy. And that content is in 30 languages and has been shared throughout the world. And that's really about, how do we just spread this information? And what I'm working on now is how can we take this information and actually develop new technology, new tools that perhaps can do a better job at helping people who haven't been helped previously. So the structure for my talk is I'm going to share with you 3 things that I learned about pain that I felt had the most influence on me, that really inspired me. And these are 3 things that I think give a lot of hope, are very optimistic, showing how things can potentially get better. And these are ideas also that the ideas themselves actually point to the future of treatment, what they open up kind of new avenues. So I'm going to share these 3 ideas with you, and then I'm going to give you a little bit of an overview of what's going on in innovation right now, some of the new rehabilitation tools that are being developed and tested, and then we'll open it up for questions. So the first idea that I want to share is that the divide between psychology and biology is disappearing. That we used to think that pain was either psychological or biological. Either you had a physical problem or you had a mental problem. And if you had a physical problem, you needed physical treatment. And if you had a mental problem, you needed mental treatment. And many patients who had pain, the doctors, if they could not find the source of the pain, they would immediately say, well, it's in your head, or it's from some sort of psychological issue, and you need to see a psychologist. And that's kind of where people were left. And the flip side of that is that the people where the doctors felt that there was something that they could see, so it was just a physical treatment. Okay, just do this surgery or just do this physical treatment, and there was like no thinking about psychology at all. And that divide right now is disappearing. And I'm going to share with you 3 examples from research that inspired me and that I think really drive this point home. So the first is a study that was very interesting. What the researchers did was they gave healthy individuals a blood pressure cuff. And if you ever had like a blood pressure cuff squeezed really, really tight on your arm, it can get extremely painful. And basically the study was quite simple. They would put the blood pressure cuff on the volunteers' arms, and they would ask them to keep it on as long as possible. But what the researchers did was they split the group in half. Half of the group, they told them, this is a new way to strengthen your muscles. And the longer you keep this blood pressure cuff on, the more your muscles are going to get stronger. The more it hurts, the more you're actually going to be getting stronger. And the other group, they told them, we're just testing how much you can tolerate pain. And as you can imagine, the amount of time that people were able to keep the blood pressure cuff on is completely different. The people who thought that this was a way that they were actually strengthening muscles, they were able to keep the blood pressure cuff on much longer. And amazingly, the researchers were able to see and to demonstrate that the brains of these individuals were pouring out opioid chemicals and endocannabinoid chemicals. So that context of what the pain meant actually changed not just how much you could tolerate the pain, but actually the physiology in the body of what chemicals the brain was producing to relieve the pain. That's the first example. The second example is a study that I call the pinch or punch study. In this study, what the researchers did was they told participants, it wasn't patients, healthy volunteers, we're either going to touch you with a feather or we're going to give you a pinch. And you would expect the pinch is going to be moderately painful, and the feather is going to feel kind of nice, like a gentle touch should feel. And what the researchers found was, as they predicted, when they gave someone the feather, the gentle touch, the brain lit up like a reward. You would expect when you're getting a reward, and the body was relaxed. There was no stress activity in the body. But when they got the pinch, predictably, the brain activated all these pain neurons, and you could actually measure that the body was getting very stressed. So this was one group, pretty predictable. The other group, they changed it. They said, we're either going to give you a pinch, that same pinch they were giving before, or we're going to give you like the equivalent of a punch in the face, a really, really strong noxious stimuli. And in this group, when the patients got this, really strong noxious stimuli, as you expected, it was very painful, and they would, the brain lit up as you would expect that a person was in pain. But now when they got that gentle pinch, it actually wouldn't hurt, and it would feel actually pleasurable. and the brain would activate with all this reward and pleasure activity, because from the brain's perspective, this pinch meant that you didn't get this much more severe noxious stimuli. So the same stimulus, when it was either a pinch or a feather, that pinch was painful and the body reacted with stress and pain activity in the brain. Yet when the choice was that same pinch or a very strong noxious stimuli, the brain interpreted that stimuli as pleasurable and rewarding. And so just the context, once again, completely changed how the sensation felt and how the brain reacted chemically and neuronally to that stimuli. The last example that I think is a great example of a complete breakdown between psychology and biology is a study that looked at what happens when you're given opioid pain medication and you don't know that you're getting it. So in this study, the participants are hooked up to an IV and they don't know actually what's coming through the IV. And the researchers tell the participants, we're going to start flushing the line with some saline. So there's no medication, we're just getting the line ready. But actually they started giving one of the most powerful opioid pain medications known to man. And they would test and see, okay, how much is this opioid medication actually helping the participant when they don't know they're getting it. And they found that it only helped a little bit. There's a very small amount of pain relief from this hidden medication. Then the researchers said, okay, we're going to start giving you the medication now. But really they were getting the medication the whole time. And so now once the participant knew that they were getting the medication, the pain relief increased tremendously, and you can actually see it in the brain, that there's a whole different activity in the brain just from now being told that you're getting the pain medication. And then the researchers did something quite sneaky, is they told the participants that they were going to take the medication away, but they didn't. So the participants now thought that their medication had been taken away from them, even though they're still getting the same opioid pain medication, and the pain relief was abolished completely. And so knowing or being aware or thinking that your pain medication is being taken away actually reversed the effects of this very, very powerful pain drug. And it wasn't just the patient's self-report, they could actually see this kind of changes in activity in the brain. And so what this says is that even a medication, the most physical of all interventions, the way that it's delivered, how it's explained, how you understand what's going on, completely changes how that medication interacts with your body. So that divide between the psychology and the biology completely breaks down. Why is this hopeful? Why does this matter? Well, number one, it indicates that there may be many ways that we can influence pain. So there's many doors. All these different factors, the psychological factors and these physical factors, all of these are different doors that we can use all together and can influence pain in a positive way. The next thing that I think this really as a practical implication is that treatment always needs to be targeting both these factors. We always need to think about what are we doing to change physiology in the body with something like a medication or potentially even a surgery if needed, but at the same time still addressing fear and anxiety and anger and loneliness and stress and grief and all of those other factors that are part of what it is to live with persistent pain. So treatment should never just be for one of these things. And also, one more thing, which I think is really, really important, is that if someone improves after a psychological treatment, it doesn't mean that the pain was all in their head or that there was never a problem to begin with. Just because a psychological intervention of some sort was helpful doesn't in any way mean that the pain was less real or less physical or that the patient was making it up. And that's really, really important. So that was the first thing that I wanted to share, is just that the divide between psychology and biology is completely broken down. The second thing that I wanted to share is that pain is not a one-way street. So the way I was taught or thought about pain was that, pain signals travel from the body parts to the brain, this kind of one-way ticket up. And we now know that this is not true. And really, if you think about some very common examples, like, many of us have heard stories of people who've been bitten by a shark or been shot with a bullet in a war and reported no pain at the time. And that doesn't really make sense, because they have this severe tissue damage, yet you assume all these signals are coming up to the brain, but they're not reporting pain. So what's going on? The flip side of that is anyone who's experienced allodynia, where a very, very gentle touch causes severe, severe pain. Clearly it's not just some gentle signals, going up. There's a lot more going on. Something else is really either, amplifying or inhibiting and turning the volume down. So in the 1970s, actually it's a long time ago, scientists discovered that just as there's pathways that bring the information up from our body to our brain, there's pathways that go down from the brain, down the spinal cord to the rest of the body that act like modulators. They act like volume knobs, and they're constantly adjusting the volume of information that's coming up. And so even if you have a very big injury and there was all this information coming up to your brain, if the brain is sending signals down that turn the volume down, you would actually not feel pain, or you'll feel less pain. And the flip side is, even if you have a very small signal coming up from your body, if your brain is sending down these signals that turn the volume up, a very small signal, a very gentle touch can be felt, really felt, as a very, very severe pain, because these pathways are amplifying the signal. I think that the simplest metaphor for this system, the way I think about it, is when I go to a concert and I see the sound engineer has one of those giant boards with all those knobs and all the sliders. And what I hear in the audience is not exactly what the musician's doing, it's what they're doing filtered through that soundboard. And if the sound engineer turns the volume down, even if that person on stage is screaming into the microphone, I might not hear anything. And the flip side is, if the sound engineer turns the volume up, even if that person on stage is whispering, I might hear them very loud. And so it's really these modulators, these knobs, that are actually controlling the end experience of how much pain we feel, regardless of how big the stimuli is. What's really amazing is that even though this was discovered in the 1970s, in the last few years, scientists are now able to image and see these pathways. So in technologies like fMRI and other techniques, scientists can actually now see these pathways in action. And for example, if you give someone a noxious stimuli, like you put something really hot on their arm, you'll see that activity in the spinal cord. But if you give them a distracting cognitive task, which inhibits pain, you can actually look at the spinal cord and you'll see that that activity from the arm disappears with the noxious stimuli. So you can actually now image these pathways and see them. We have two general pathways, one that turns the volume up and one that turns the volume down. And the balance between those two pathways ultimately results in whether our system overall is amplifying or turning the volume down. And due to genetic reasons that we now know, some people's system, the neurons, the pathways that turn the volume up are overactive, or due to early life experiences like trauma, like severe stress, that can result in long-term changes in the system where the pathways that turn the volume up become overactive. And then once you get an injury years later, it's more likely to be amplified. So we now know that genetics are playing a big role in early life experiences in these pathways. We know that animals have these pathways also. It's not just mammals. Fish, birds, and reptiles also have this system. And we think that it's there from an evolutionary perspective for survival, that if you're being chased by a predator, you don't want to be paying attention to a small injury, a small bite. You want to be focused on escape and survival. And we think that that might be the reason why these systems exist and why they've evolved. We know that this system, the master control on this system, is in the brainstem at the bottom of the brain, just above the spinal cord. But this system interacts with all sorts of other parts of the brain, which talk to it and tell it when to activate or not. And the last thing, this is an interesting fact about this system, which is particularly relevant for CRPS. This system, and here's a science word, somatotopic. This system is arranged in a somatotopic way. What that means is that the brain can turn the volume up or down on a specific body part. It's not just a system that says turn all pain up or turn all pain down. The brain can actually say turn down the volume of pain in the hand, or turn down the volume, or turn up the volume of pain in the hand. So it's arranged in a somatotopic way. It can actually direct these effects to specific body parts. So who cares? Why is this? I mean, I find it very interesting, but why is this meaningful? What's the point? So number one, this understanding explains some of the weirdness of pain. Why sometimes very small stimuli create lots of pain, and why sometimes really big injuries don't create much pain at all. So it explains a lot. It also explains why some people are more vulnerable to developing chronic pain, because the pre-existing state of this system, of this modulatory system, is going to make some people more vulnerable or less vulnerable to developing chronic pain. And the last thing is, we now know that in therapy or treatment, we want to target this system. So we're thinking, what can we do to increase activity in the neurons that turn the volume down? And what can we do to decrease activity in the neurons that turn the volume up? So that was the second thing I learned about pain that I thought was really interesting. Pain is not a one-way street, and it's being modulated by these top-down pathways from the brain. The last pain fact that I want to share is that persistent pain is not the same as acute pain. So we used to think that if someone has pain for 2 years, that's basically acute pain, the initial pain that's just stuck around for too long. And you would treat it the same way. So whatever you would do to treat someone who had pain after a month, you'd give the same treatment to someone who's had pain after 6 months or 6 years, because it's the same pain, it's just stuck around for longer. So we now know that that is not true at all. The pain system is constantly changing. That's what we call pain plasticity. Pain plasticity are changes that take place in the nerves in our pain system. And chronic pain, or what I prefer to use the phrase persistent pain, is a completely different entity than acute pain. So we now know that the nerve endings in the skin, in the muscles, those nerve endings change and they become more sensitive. They get different receptors on them and they physically change and become more sensitive. We now know that the synapses, the switching stations in the spinal cord, that the neurons sprout new connections. The neurons actually grow outward and they make connections to different paths that they weren't connected to before. So if you had a channel for pain-related information or information about noxious information, and then you had a separate pathway about, for gentle touch or pleasurable touch, the neurons can sprout and actually create cross connections between these pathways. So now when you turn on the gentle touch pathway, those neurons are sprouting and it's activating what was just the noxious information pathway. So there are these crosstalk in the spinal cord. The pathways I was talking about earlier, those pathways that turn the volume up and down, they change and become more or less active. And we now know that the brain does something really amazing. The brain shifts how it creates pain. So an amazing study was done with people with back pain. And it looked at how the brain was activating when they felt back pain in the beginning. So for the first few months, people would say, I have a 7 out of 10 back pain in my lower left back. And you would see a very specific activity in the brain. Let's just say it's right here. It's obviously more complicated than that, but let's just say it's right here. They would watch these individuals over time. Some people would recover and that activity would go away. And other people would transition into the persistent or chronic phase of the condition. They would feel the pain as the same. They would say, I still have that 7 out of 10 pain in my left lower back. But when the scientists look at the brain, now it's this part of the brain that's creating this sensation. So the brain completely shifts how it creates the sensation. And so all of these changes all together, which are called maladaptive neuroplasticity or unhelpful pain plasticity, the nervous system is different. This actual circuitry in the nervous system that's producing pain is an entirely different system than the acute pain phase. Even if it feels the same, it's actually a different condition. It's a different entity. Now, why is this so important? Number one, we now know that treatments that are really helpful for acute pain might not be helpful at all in the persistent state. And not only that, they may even be counterproductive. So this may have to do with medications. Medications that are helpful in the early phase are not helpful later on. But also even behavioral strategies. So something like rest, avoiding any pain. These are things that can be really, really helpful in early phase. But later on in a treatment, some degree of movement is often a critical piece of moving forward in these conditions. And so strategies of rest and avoid movement, which may be helpful in the beginning, actually become counterproductive for this different type of system. It's also very optimistic. We now know that just like the pain system can change and become hypersensitive and all of this maladaptive plasticity can occur, things can also go in the other direction, that we can have a positive neuroplasticity, that things can also shift in a positive direction. We can see it. We can actually see it now on the brain scans that different good, helpful interventions for pain actually can reverse some of these changes, which is extremely optimistic. And this is new information that we've only learned about in the recent years. Specific to CRPS, a study just came out in one intervention of CRPS, which is graded motor imagery. I'm sure some people have used it or certainly know about it in this meeting. So a study came out recently showing actual changes in the brain after people have done that kind of intervention. We've also seen that with sensory training, something I'm going to talk about a little bit in a few minutes, that also with these kinds of sensory training interventions, we can see healthy changes in the brain. Also very interesting, it could be that some of these kinds of interventions can prevent that plasticity from occurring. So in people that we identify early on as being at high risk of developing chronic pain or high risk for a condition like CRPS, doing these kinds of rehab interventions early on may be even able to prevent or slow down that transition of maladaptive neuroplasticity. And it's not just rehabilitation, even surgery. We now know that not all surgeries are warranted, right? Surgery is not the answer to everything, but there are times when surgery is helpful. And one example where surgery is often helpful is total hip replacement. And we now know that after a successful total hip replacement for a certain type of hip pain, that you can actually see also a reversing of some of that maladaptive plasticity, that the brain actually changes in a positive way. So targeting neuroplasticity is already the gold standard for conditions like CRPS. So graded motor imagery, for example, is a gold standard therapy for CRPS. So we're already seeing now that this is now the way to treat these conditions. It's being recognized in the clinical guidelines. And the next generation of therapies, innovation, are all working on how can we optimize that? How can we measure this maladaptive neuroplasticity? And how can we get even better at resolving it, at improving it, and promoting a healthy neuroplasticity? Okay, so those are the three things about pain that I wanted to share. Just to recap, the first one is that the divide between psychology and biology is disappearing. The second is that pain is not a one-way street. We have all these modulators that adjust the volume on pain-related nerve signals. And the last one is that persistent pain is not the same thing as acute pain, and it needs to be treated differently. Okay, so now I want to share a little bit about moving forward. So what are some of the interesting things that are going on in the field of pain innovation and in technology? So when we look at technology and pain care, and I'm talking very specifically about rehabilitation. I'm not talking about surgeries. I'm not talking about stimulators. I'm talking very specifically about rehabilitation approaches. So we see two main categories of technology innovation. So one category is using technology to deliver the traditional treatments, but to deliver them, give more access, make them more easily accessible. Maybe just by delivering it through technology, people can engage in it more than having to go into a therapist. So it's delivering traditional care, but using technology to deliver that. The second category is where technology, because of new technology that's available that wasn't available before, we're actually reimagining entirely new approaches to treating these conditions and really innovating not just in the technology or the delivery of care, but really innovating in what could care look like, complete reimagining it. And we'll talk a little bit about both of those categories in a minute. This is a really, there's a lot of activity going on in this right now, and even on the governmental level. So the FDA and the government is in the process now of trying to figure out how to regulate these kinds of therapies, this kind of innovation? How do you ensure that it's working? How do you keep people safe? What kinds of policies should be adopted? So there's a lot going on right now in terms of regulation. And there's also a lot going on in terms of reimbursement. So who is going to pay for these new technologies? How is it going to get to patients? How much is it going to cost? And I think that one very promising avenue to look at is what's going on in Germany. So the German government created a system called DIGA, and the DIGA system basically vets new technologies. They have several pain therapies, but also other apps and things for all sorts of chronic conditions and on non-chronic conditions. And so the government says that these apps that have been approved, that have been vetted, the government will pay for it. And those are apps, some of those apps cost 600-700 euros, but it's an entirely new model where the government now actually pays for these kinds of technologies. And that model of what's going on in Germany is now going to be replicated in other European countries. I think it's going to be a long while before we see something similar in the US, but those are some of the systems that are being looked at. And in the German marketplace, for example, even once they approve these products, still many of the doctors don't know about it, they don't prescribe it, and it's going to take a lot of work to bring awareness to these solutions, as a lot of it's going to come from patients actually asking the doctors for it, and that bottom-up demand, because the doctors aren't even aware of these options that are available. So let's talk about some notable examples of interesting innovations and interesting technologies. So the first is the CBT apps. I'm assuming that many people on this call have heard of CBT or maybe tried CBT, cognitive behavioral therapy. It's one of the gold standard approaches for different types of chronic pain. But it's very hard to find a therapist. So if CBT is something that you're looking for, it's something that you want to try, there's very few therapists who specialize in CBT for pain. Many who specialize in it for depression, anxiety, and other indications, but there's very few who actually are specializing in pain. And so there's a whole bunch of cognitive behavioral therapy apps that are coming out that are bringing that kind of approach to people and making it more accessible. There's all sorts of interesting things going on in terms of exercise apps. So the main innovation in the exercise applications is that the technology has gotten so good that the phone camera can now see you and really know the position of your body. And so if a physical exercise is recommended, either by some algorithm or by a therapist, and you put the phone up in front of you, the phone can watch you do the exercise and give you feedback about how you're doing it, whether it's being done well or not. The unfortunate fact with those applications, those technologies, is that they're really being used for musculoskeletal care. So, people who have a recent back pain, recent aches in their joints, and these companies are selling them, generally the companies that create these technologies are selling them to large corporations to help people who have general aches and pains in the workplace. But these systems are not developed for people who have conditions like CRPS, where many of the exercises that the system is delivering are not appropriate for someone who has CRPS or are not graded in that way. And so I'm hopeful that at some point those technologies will be adapted for conditions like neuropathic pain and CRPS. It's not there yet. Another area that's a lot of work is going on in is VR, and virtual reality. Now, you might hear virtual reality and just think, okay, virtual reality is virtual reality, but there's a lot of different things, a lot of different solutions that are in virtual reality. And so if you're exploring a virtual reality solution, you might want to think about what kind is it? And here are a few examples. So there's virtual reality solutions that are focused on distraction. So just putting you in an immersive environment where you don't feel the pain anymore. A lot of the early work on VR was done with people who were having bandages changed, people who had had wounds. And they found that putting people in these immersive environments while they were having these very painful procedures really decreased the pain. And they were able to corroborate that with all sorts of brain scanning technology. So there are these immersive environments. There's relaxation environments, so putting people into VR and relaxing, comfortable, pleasant environments. And there's several companies also that have a biofeedback component where it's maybe measuring your heart rate or measuring your stress levels through a sweat sensor. And as you're relaxing, the environment is changing and giving you that feedback and helping you improve your mastery over that self-regulation of relaxation. There's some companies that are now taking CBT and applying CBT in VR. And so by being in this immersive environment, perhaps learning the skills associated with CBT may be more engaging or more effective. One of those things is particularly fear exposure. So anybody who's been dealing with pain for a long time is obviously and naturally going to want to avoid doing things that provoke that pain. But very often, as part of rehabilitation, there needs to be some engagement with those feared activities and very slowly and gradually re-engaging in things that are avoided. And doing that in VR is something that's very exciting. And there are several companies working on that, doing those feared activities. And even if someone has a specific associations with, let's say, a warehouse environment, maybe it's where they got their injury, within the VR, you can go into that environment and you can start to explore and experience it in a safe way and in a graduated way. But there's also other things that are going on in VR that are really fascinating, which is using illusions in VR. So giving fake feedback. And I'll give a few examples of that. We now know that the brain takes in, when you feel pain, let's say when you turn your neck, so your brain is taking in information from your neck, but your brain is also taking information in from your eyes, how far you're moving, where you are in the room. And if you're someone who's always had pain, every time you turn your head, you get pain, even just moving the eyes to look to the side actually can trigger pain. And so some VR apps are experimenting with giving false visual feedback. So you see that you're not moving very far, even when you're moving further. And it's a way, it's kind of like a hack, a brain hack or a trick or an illusion to actually make it easier for the body to do certain movements by changing the kind of feedback, the visual feedback you're getting. There's some interesting work also putting things on the virtual body. So if you have an area that is really sensitive or that you protect a lot, what would happen if you actually put a shield on it in virtual reality? You actually protect the area in the virtual space. How does that change pain sensitivity? There's some really interesting research going on there. And lastly on this, there's interesting research. Many people with CRPS report that the body part feels like it's a different shape, maybe larger, maybe smaller, maybe a strange shape. And there's all sorts of interesting work going on about giving people illusions of the arm or body part shrinking or expanding and exploring how that actually changes the experience. So those are some of the things that are going on in VR. In terms of what's available today, it's generally the distraction, relaxation, and biofeedback applications. And some of those other things I mentioned are a little bit earlier on in the development cycle. We mentioned graded motor imagery. For those of you who don't know, it's a series of different brain exercises and movement exercises and movement imagery exercises. The research that's been done on it is quite promising, but when you look into the protocols that are used in the research, it requires a very intensive amount of practice. It's not something that's done for 10 minutes or 15 minutes a day. It's a very, very intensive protocol of something that's done really on an hourly basis for several weeks. Finding ways to use technology to deliver it better, to make it more engaging, to track the engagement in it. There's several groups working on improving graded motor imagery and delivering it through apps and more engaging experiences that really will allow people to engage in it to the degree that's required to really to have the effect. I see a lot of questions here. I'm going to share about another 5 minutes, and then we'll start going through the questions. So I want to mention artificial intelligence. You'll hear a lot about artificial intelligence in the news. There's a lot going on in the pain space with artificial intelligence in a few different ways. A lot of it has to do with looking at brain activity and trying to decipher from brain activity what people are experiencing, but I don't want to focus on that right now. What I'm really interested in is the AI that's being used for therapy. So how can AI be used for therapy? There's two main ways that are the most frequent, I think, right now. One is all about recognizing patterns. And so we know that everybody is different. We know that people respond to different therapies. There's no one therapy that works for everyone or doesn't work for everyone. It's There's different people respond to different things. So one of the things that AI can do and is really good at is recognizing those patterns. And so saying, okay, here's a bunch of people who did a therapy, here's who it worked for, here's who it didn't work for. What are the characteristics of these different groups? And it's looking at many, many different characteristics. And can we start to predict who is going to be more likely to respond to a certain intervention? And then when you show up for therapy to the system and you input all this information that it learns about you, it can say, okay, people like you tend to benefit from this kind of approach or from that kind of approach. So that's one way that AI is personalizing therapy. There's another way that I think is really the most exciting, that I've spent the most time looking into, is reinforcement learning. So this is a kind of AI where the AI itself runs experiments. So you give the AI a general framework of, these are all the things that might be helpful. Here's a list of things that are safe to do, that are safe and potentially effective approaches for an individual, but there's no way to know what's actually going to be good for this individual. And the AI itself will start to experiment and say, okay, let's try this. Let's collect information from the patient. Was it helpful? Wasn't it helpful? Now let's try something else. And the AI itself will actually, for each individual person, start to figure out what is most helpful for them. And these systems can also look at different factors, like what's most helpful for this person when it's a rainy day might not be the same thing that's helpful when it's a sunny day, or when you're at home versus when you're at work. And so those are some of the things that these systems are working on. They're very difficult. We're quite a far away from that really being a reality, and in particularly in pain, when many of the effects of the therapies are not immediate, right? It's not a quick feedback to the system. That worked, that didn't work. It's much more fuzzy, and there's a lot of other factors at play. And so those systems also are not quite ready. But already the VA in the US has started experimenting with that kind of algorithms to see how can you optimize cognitive behavioral therapy, what kind of aspect of the cognitive behavioral therapy, which specific techniques are going to be helpful for a particular individual. And the last technology that I want to share with you is the one that I'm working on, which is sensory training. So I was inspired by research that was really first done in 2001 with people who had phantom limb pain, that showed that doing sensory perception exercises, so actually training how the brain is perceiving information from the body, doing these sensory exercises, thousands of repetitions, could significantly relieve pain and also change how sensory information is represented in the brain. And so these were studies that were done, as I mentioned, with phantom limb patients, but it showed that these kinds of sensory exercises were quite effective and could really promote healthy neuroplasticity. In 2008, 2009, some researchers took those same techniques and tried it in CRPS in several different studies, and found that also in CRPS that these kinds of sensory trainings were very helpful for pain and also improving different aspects of the sensory nervous system. And they specifically tested passive stimulation, which I'm sure many people here have undergone with a therapist, like passive desensitization, versus sensory perception training, which I will explain a little bit more in a moment. And they found that these kinds of sensory exercises are much more effective than just a simple passive stimulation or desensitization. But they're very hard to deliver. These kinds of exercises require thousands of repetitions. You need someone else to touch you and do the exercise with. And so that was the inspiration for our company, where we are developing haptic video games. So these are video games that you play on an app that are connected to a haptic device that gives a very gentle sensation on the body. And you play games that are based on sensory perception exercises. So you feel a sensation on your body, and that sensation is actually the clue on how to solve a puzzle in a video game. So you play the video game using what you feel to solve the game, and the system, the game, is learning how the brain is processing information from the body, because the game knows what you should feel. And if you don't feel that, if you input things into the game incorrectly, the game is learning how your brain is perceiving or misperceiving information from the body. We do a lot of different types of sensory exercises, and I'll give just one example so it's a little bit clearer what I'm talking about. You can also see pictures of our system on our website at TrainPain.com. you can see some photographs of the haptic device and also our games. So one of the exercises that we do is we have the haptic stimulator on 2 different body parts. So for example, with folks who have CRPS who've tried this, they put one stimulator near. If they can put it on the painful body part, they put it on the painful body part. Very often they're putting it near, not on the painful body part. And they put the other stimulator on a completely different body part, a body part that doesn't have any pain, on the opposite side of the body. And what we do is we give a little bit of stimulation to both of these body parts that are different. And we play a game where the patient has to selectively filter information from one body part versus the other. So we'll say to them, what's going on in this body part, while at the same time they need to ignore distractions coming from the other body part, or they need to pay attention to this body part over here while ignoring distractions that are coming from this body part. And we do these exercises hundreds of times, and we're actually able to measure how the brain prioritizes or how well it's able to filter out sensations from the painful body part as compared to the non-painful body part. And over time, as we're doing these exercises, we're training the brain to get more flexible in how it shifts attention, in how it prioritizes what signals the volume is turned up on and what signals the volume is turned down on. And the kinds of exercises that we're doing have been studied in neuroimaging with brain imaging. And we know that these kinds of sensory exercises activate those inhibitory neurons in the brain, those neurons in the brain that turn the volume down. So this is a new intervention that we've been developing. And we've done several small trials. And we're actually getting ready to begin our first trial in CRPS. I can't announce it formally yet, but it'll be at a major hospital and it'll be focused on children with CRPS. And we hope to have that, recruiting in the coming months. And so I'm hopeful that, people from the community will share about that and hopefully participate in that study. And we're also going to be releasing this technology as a low-cost tool and making it available pretty soon. The system was just finished, and we're hoping already in the next weeks to months, it will already be available for people to have at home and start using. So that's a technology that we're working on. So in summary, the future is bright. So there is both this mix of new understandings of pain, so understanding how the system is working, understanding the plasticity that goes on in the system, but also all this new technology, all these tools that are available now that weren't ever available before, opening up new opportunities. So that new knowledge plus the new technology is leading to a whole renaissance really in rethinking how pain care can be delivered. And I'm quite optimistic that in the coming years, we're going to be seeing some tools that are dramatically more effective than what we've had until now. And I'd like to close with an invitation to everybody to get involved. So we need to, number one, promote awareness of all of this new science about pain. We need to promote awareness of these new tools and technologies that are available so people can actually start using them, that doctors can know about them as options. And also, we need to support multidisciplinary teams. So building these new technologies, if it's built by technology folks, it's going to be really bad if they're doing it in isolation, because they're not really going to understand the people that they need to be building it for. There need to be healthcare professionals, there needs to be patients, the technology folks, people from the entertainment industry, so that these products are actually enjoyable and engaging. And we need to start really building these groups, these innovation groups, where people are coming together from these many industries and working together to innovate and bring things forward.
And I just wanted to thank you, Dr. Schneider, for coming back and speaking to our warriors, and thank you for all the warriors who are online now. And I just want to say, just once again, thank you for this great information as always.
Thank you very much.